All right, so good evening, everyone. Tonight, we'll be covering Chapter 24, Psychiatric Emergencies. As AEMTs, you will often encounter patients in mental health crisis, right? So these emergencies can stem from medical conditions, mental illnesses, it can be substance abuse, it can even be stress. So tonight, what we're going to do is we're going to focus on recognizing and managing psychiatric conditions like acute psychosis, suicidal risk, agitated delirium, while at the same time ensuring both patient and scene safety while we're there. So by the end of the session, you will have a solid understanding of how to approach these situations with confidence and care for your patient, being an advocate, right? So let's go ahead and get started with this. All right. So again, today we'll be focusing on how to apply fundamental knowledge in providing both basic and advanced care for acutely ill patients based on your assessment findings. So on the psychiatric side, we're going to cover how to recognize behaviors that pose risk to you, the patient, and others. This includes assessing, managing psychiatric emergencies. These psychiatric emergencies are going to be things like acute psychosis, suicidal patients, and agitated delirium. We're also going to review the basic principles of the mental health system to help you navigate these situations, right? So in your position as a provider, you'll frequently encounter these patients, and you'll encounter patients that are going to have psychological issues or behavioral crisis all the time. It's going to happen if you stay in it long enough. And it may be the result from a medical condition, a mental illness, or a mind altering substance, or even that stress that we talked about, right? So by the end of the session, that you'll have this better understanding of how to manage these situations safely and effectively. All right. So being a provider, you're going to have these patients all the time. Like I said, these are going to require very quick thinking and careful assessment, as the cause of the these crises can vary. So we're going to go over some common reasons for these to be called medical emergencies. So you have medical conditions starting off. So conditions like hypoglycemia, hypoxia, or head injuries can cause confusion or aggression, things like that. We're always going to consider if a medical issue is driving the behavior, right? We're going to do a thorough assessment, and that's going to help us uncover those causes for that. Up next, it could be a mental illness. So patients with mental illness may experience hallucinations or severe distress. So while this might seem like the primary cause, remember to rule out other conditions first for that. Okay. So what that's going to involve is gathering history from bystanders or family. That may be very crucial to be able to make a definitive decision if that's going to be the issue, being mental illness. All right. Up next, we got mind altering substances. So substance abuse, intoxication, or overdose can significantly affect behavior. So we're going to consider if drugs or alcohol are involved and whether specific interventions like naloxone might be needed for these patients. All right, then we have stress. All right, so everybody here has some sort of stress that comes upon them day to day, right? So this could be stress from a recent trauma or life changes that can lead to a behavioral crisis. So your role includes calming the situation while gathering this important information so that we can make a definitive decision on what's going on. All right, so let's think of it like this. So imagine that you arrive to find a 45-year-old male acting very erratically at home. His wife mentions that he has hypertension and depression, and today he just feels dizzy. So now he's sweating, he's agitated, he's combative. What do you suspect might be this behavior, and how do you ensure safety while you're assessing this patient? Does anybody want to pipe up on that one? Or if you want me to read it again, I will. It came up with this case scenario for us to start us off on the bat, trying to figure out something. So you have a 45-year-old male that's acting erratically. All right. Wife mentions hypertension and depression, and today he's feeling dizzy, right? So he's sweating, he's agitated, and he's combative. So the question was, What do you suspect might be causing the behavior, and how do you ensure safety while you're assessing him? All right, so I want everybody to think about this scenario, this type of scenario as we go, because I may pop this up again. And as we go through, maybe we have some really good answers to it. So just think about this scenario as we move forward. All right, so let's talk about some common myths that surround mental health. So, first, everyone experiences an emotional crisis at some point. Right? Even healthy people might exhibit behaviors that seem like mental illness from time to time. So, as a provider, it's going to be important not to assume someone has a mental illness based on brief behaviors. Okay. So, this is going to be especially true when we're assessing patients. So, your role is to focus on what's happening in the moment, not to diagnose long term mental health conditions, right? So, one major misconception is that feeling bad or feeling depressed automatically means someone is mentally ill. So, there are many legitimate reasons that people feel down. We all know it. Things such as going through a divorce, losing a job, or the death of a loved one. Sadness is, in these cases, is a normal response, not a sign of illness. Right. So, however, though, if this sadness persists or if it disrupts a person's ability to function, it could indicate a more serious problem for this patient. So, as an AEMT, recognizing when a patient's emotional state might be part of a bigger issue is going to be very critical. So, another myth is that people with mental health conditions are always dangerous or violent. So, in reality, only a small percentage of individuals with mental health issues fall into this category of dangerous or violent. So, while you can't always know what triggered a person's crisis, your assessment should focus on identifying any potential violence. Okay. So, in this, we're going to look for behavior, or we may look for verbal threats, which could signal a higher risk of escalation. So being able to predict this helps you maintain safety and to manage the scene effectively for these patients and yourself. All right. So when we talk about behavioral emergencies, we're focusing on what we can observe, right? So how someone responds to their environment. So these responses can be obvious or they can be subtle. And most of the time, people react in ways that make sense based on the situation. However, sometimes stress becomes so overwhelming that a person can't cope in their usual way. Okay. So when this happens, their behavior may change temporarily and they may not seem that whatever they changes to, it may not seem appropriate or normal. Okay. So what's important for us to remember is that the definition of normal, it varies greatly. Uh, So there's things like it can depend on cultural or ethnic backgrounds, and what is acceptable in one group may not be in another. However, in general, abnormal behavior is always, or is not always, but anything that strays from societal norms. Okay. Societal norms. And it starts to interfere with a person's well-being or ability to function, how that happens. So if it starts to do that, then that may be an issue. So this might even it could also be that they pose a danger to themselves or others. So a piece of that, right? They pose a danger to themselves or others. It doesn't meet societal norms would be the big one, right? Not expectations and norms. Usual. A behavioral crisis occurs when somebody's reaction to stress, or even it may be someone's their individual reaction to stress more of, or events that disrupt their ability to carry out normal daily activities. All right. So if this disruption becomes a regular pattern, it's more likely to be classified as a mental health issue at that point. So this is going to be more of a mental health issue rather than an isolated mental health incident. All right. So short term behavioral changes, especially in response to stress, are perfectly normal. However, if these patterns last for at least a month, it could be a sign of a more significant mental health concern, such as a chronic depression issue. In a psychiatric emergency, things escalate even further from that, right? So the person may become agitated, they could be violent, or they could pose an immediate threat to themselves or others. So it's going to be critical to recognize that not all psychiatric emergencies involve violence, but they are more serious than typical behavioral crisis. All right, so mental health issues are more widespread than many people even realize. So according to the National Institute of Mental Health, 1 in 5 Americans will experience some type of mental disorder at some point in their life. So as an AEMT, understanding the scope of this issue is going to help you prepare for the likelihood of encountering a patient with mental health disorders during your practice, right? So a mental disorder is going to be defined as an illness that presents with psychological or behavioral symptoms, and it can impair a person's ability to function in everyday life. So these disorders don't have a single cause. In fact, they can stem from a variety of factors such as social, psychological, genetic, physical, chemical, or biological disturbances, right? So, for example, a person may experience a behavioral change due to a chemical imbalance in the brain. They may have a stressful life event, or they can even have a genetic predisposition to a mental health disorder. So, in the field, you'll see that behavioral alterations can have many different causes, and it's important to consider that the whole picture during your assessment. Look, you got to consider the whole thing, the holistic review, right? So, what we're going to do is sorry, I had a brain function disorder right there. See a brain order dysfunction. I can't even have a speaking dysfunction now. So we're going to look for both the immediate symptoms of this pushing forward and the possible underlying causes of these changes in behavior, right? So in your book, if you look at table 2-1, I'm sorry, 2-1, if you look at table 24-1, it's going to list the common causes of behavioral alterations, right? So this can serve as a helpful reference for you in understanding what might be triggering a patient's current mental state. All right. So when assessing a patient, you're going to ask yourself, what could be driving this behavior? Could it be a temporary reaction to stress, or is there something deeper going on? Is there an ongoing mental issue that may require further intervention here? That's some things that we have to look at. All right, so abnormal behavior or altered mental status, it can be a result from a variety of causes, right? We've talked about it in several chapters. So as an AEMT, it's important to recognize these during patient assessment. So behavioral emergencies often arise from both psychological and physical factors in this. So for example, sudden grief or emotional conflicts can push someone beyond their normal coping mechanisms, right? And this can cause dramatic shifts in behavior. Similarly, pre-existing psychological problems like pressure or anxiety can exacerbate or even trigger stress. So sudden illness can also lead to altered behavior. A patient with a stroke, an infection, or even a head injury may become confused or erratic. So we're always going to consider recent trauma when we're evaluating any changes in behavior, especially head injuries, okay, or TBI type patients. So this can have an immediate and it can also have severe effects on the mental status of someone. Also, drug or alcohol intoxication is another common cause of behavioral emergencies. So whether the result of intoxication or whether the result of the intoxication, the overdose, or withdrawal, these substances can profoundly alter a behavior and it can require careful assessment and management for that patient. There's other things too. So you have diseases of the brain, such as like when we're talking about Alzheimer's. So it can cause a gradual cognitive decline that leads to behavioral changes. It's essential to recognize more immediate physiological causes as well, such as things like hypoglycemia, where low blood sugar may lead to confusion or aggression, or hypoxia, where a lack of oxygen can result in confusion or agitation for a patient, or even unconsciousness, right? All right, so lastly, talking about environmental factors here. So, like things like exposure to extreme heat or cold, something like that, it can significantly impact a mental status for a patient. So, understanding all of this or understanding all of these, all these causes that we're talking about, it's going to allow you to quickly identify and address any underlying issues with these patients. And this is going to help you ensure that you're given that appropriate and effective treatment. All right. So, as an AEMT, you're not responsible, okay, for diagnosing the specific cause of a behavioral crisis or a psychiatric emergency. That's not what we do, right? Because who does that responsibility fall onto? It falls onto ultimately a physician. All right. So, this physician, what they're going to do is they're going to characterize the issue as either organic, which is going to be physical, or functional, which is going to be psychological. However, understanding the basic distinctions is going to help guide your assessment, right? So organic causes, what it's going to do is it's going to involve dysfunction of the brain due to physical issues. So, for example, organic brain syndrome can result from sudden illness, head trauma, seizure disorders, drugs, alcohol, things like that, the alcohol intoxication, or diseases like Alzheimer's. So these conditions physically alter the brain's function. So as an AMT, you should always be mindful for possible physical causes for a patient's altered mental status. All right. So things like low blood sugar, lack of oxygen, or poor blood flow to the brain can all lead to confusion or abnormal behavior. It's also critical to understand how a person's environment can influence their behavior as well. So, psychosocial stress, like financial hardships or relationship problems, it can trigger abnormal reactions. So, people in crisis face two choices, right? So, they can either cope with the situation or they can escape from it. So, the sociocultural environment that they come from can shape how they respond to emergencies and stress. Yeah. All right, illnesses and injury also contribute to behavioral changes. So, acute medical conditions or trauma even can cause abnormal behavior, and things like post traumatic stress disorder (PTSD) is a severe form of anxiety that develops after trauma. All right, so then lastly, you have the problem with substance use. So, whether it be alcohol, drugs, or even cigarettes, even. So it can lead to an altered mental status, often exacerbating your behavioral emergencies is what it's going to do. It's just going to exacerbate those. So recognizing that those various causes for this is going to help ensure that you approach each patient with a full understanding of potential underlying factors for this, right? All right. So now let's discuss functional disorders. So, which are going to be very different from organic causes of behavioral emergencies. So, a functional disorder means that something is affecting the person's mental state, but there's no obvious structural or physiological problem with the brain. In other words, the cause isn't rooted in a physical brain dysfunction. Easy as that. So, common examples of functional disorders are going to include things like schizophrenia, anxiety, and depression. Okay. So, these are psychiatric conditions that significantly impact a person's behavior and their mental state, but the exact cause can't be pinpointed to a brain injury or an illness. So, when we look at a psychiatric signs and symptoms, it's helpful to remember that just as the body reacts to physical stress, the mind also mobilizes certain mechanisms to restore mental balance when under physiological stress. So these symptoms can manifest across various functions, right? Such as things like consciousness, thought, mood, memory, things like that. So when someone's mental health is disrupted, their consciousness or awareness might change. Okay. Their motor activity or their speech might even become altered, or their ability to think clearly could be impaired by this. So you might also notice changes in mood or and affect. So this is going to be a change in effect is how a person displays emotions, right? So, or it can be just looking at how you notice changes in mood or effect or disruptions, right? So disruptions in this. So disruptions in like their orientation to time and place. So psychiatric symptoms affect many systems in the body, right? So this can be from how someone thinks to how they interact with the world. Uh, Understanding these symptoms is what's going to help you recognize when a patient may be struggling with a psychiatric disorder, even if the root cause isn't immediately clear for this. Okay. All right. So when approaching any behavioral emergency, the first step is going to be to perform a scene size up, right? So the environment, it can often provide vital clues about the patient's condition or the cause of the emergency itself. So we're going to take note of any signs that point out to what may have triggered the behavioral change. So this is going to be something like medication bottles, drug paraphernalia, or signs of a struggle even. So scene safety is your top priority. In behavioral emergencies, your usual AEMT skills like situational awareness, patient communication, and physical assessment are going to be very important. But you may need to employ additional management techniques to keep yourself and others safe in this situation. So we're going to be sure to assess the environment for potential hazards and to follow any types of safety guidelines, such as ensuring that you have an escape route and avoid getting between the patient and an exit. We don't want that. So additionally, we're going to keep an eye out for the mechanism of injury or any type of mechanism of injury or nature of illness that we may find. So what we're looking for is, was there a trauma that could be involved, or does the patient have an underlying medical condition like we talked about in a couple slides before? So this is going to help you guide your approach in deciding whether this is primarily a medical or is this primarily a psychiatric issue. So your ability to assess these factors quickly and effectively is going to help you to set the tone for how you manage the patient and to protect everyone else on the scene, to include yourself. Super important, right? All right. So a big thing to remember is that behavioral emergencies, they can be unpredictable. Okay. So we're always going to stay aware of our surroundings, and we're going to use our training that we've gotten to ensure a safe, effective response for that. All right. So when you begin your primary survey in a behavioral emergency, the first step is to form that general impression, right? All right. So we're looking, is this patient sick, and what's going on? What's going on right now? So as always, your safety is going to be the utmost priority, right? We're not going to undermine that. We're going to assess how the patient is responding to their environment. And we're also going to look at, is the scene dangerous? Do you need law enforcement for backup? We may need to consider whether the patient's behavior seems appropriate given the situation that's going on. For example, someone that was recently assaulted, they may be fearful of everyone, including you. Okay. They just got assaulted. So we're going to respect also, along with that, we're going to respect this patient's space, and we're going to avoid touching them without permission. We ain't going to do it. All right. So we're going to approach slowly. We're going to use that calm, non-threatening actions. And then as part of your assessment, we're going to check their pupils, see what's going on with those. Are they perla? Is one wider than the other? Do they have pinpoint pupils, blown pupils? We're going to look at all this, right? So what this is going to do variably is it's going to provide clues about possible causes of altered mental status. So if they're using like substances or if they have a medical condition, something like that. So behavioral crisis put a significant stress on a person's ability to cope, and they may not be able to respond reasonably. So this may be a temporary reaction to an acute illness, or it could be part of a chronic mental health issue. So this could be the issue where their perception of reality is then compromised. So we're going to limit the number of people that are around the patient during the assessment to avoid overwhelming that patient. Okay. So we may need to clear them out. We're going to stay alert to any signs of potential violence, such as agitation or aggression. And if necessary, we're going to separate the patient from bystanders who might be escalating the situation itself. We've probably seen that lots of times. We're always going to be aware that a patient's condition can change very rapidly, And someone who seems stable 1 second can become violent at any time. So in your assessment, we're going to focus on always, always, always airway, breathing, circulation, or XABCDE. And we're going to ensure that the airway is clear, check for adequate breathing, and we're going to monitor their pulse and their blood pressure. So we're going to look for signs of shock. We're going to look for abnormal skin conditions and emotional distress there for this behavioral emergency, possibly. And things like what we're looking for is anger or fear, things like that. And then after we do all that and we decide there's no life-threatening problems to mitigate, we're going to make a transport decision on consider whether this patient is medically stable and if we need to spend extra time on scene or where do we need to take them depending on situation protocols. All right. So let's do this. Let's take a 10-minute break. All right. Can everybody see that? It took me a little bit. Sorry about that. Awesome. Sorry about that. It was I ran a little long. I had to eat supper. Right as soon as I got in there, my wife made steak and eggs today, which is a rarity. Not that the steak and eggs is a rarity. So good. And so I had approximately about 6 minutes to eat mine. And we ate it.
Makes you feel like you're back in the EMS home.
Huh? Makes it no. Well, no, I never ate steak and eggs when I was in EMS. It was more.
I'm talking about the hurry up and scarf it down as fast as you can.
Oh yeah, most definitely. Most of the time though, it was like a churro from the gas station or something like that. Wolfing something down. One of those cold sandwiches out of the refrigerator, something like that. Yes, that I can relate to. What's crazy is that my wife will make the best meals whenever I'm teaching. So it's like she does it on purpose because she knows that it's like a challenge for her. Cause I usually do my breaks, if y'all notice, at like 6:50, 7:50, 8:50, so on and so forth. And that's how I usually do it and give a 10-minute break. Well, this time I went a little over and I went to like 7:01, which kind of freaks me out because I'm weird like that. A behavioral issue out of expectation of societal norms, right? So when I came in there, she was like, "You're late." And she was, "But that's fine because I'm not done." So I had to wolf down steak and eggs. But like I said, she makes the absolute best meals whenever I have to teach. So it's torture. I know I don't get to enjoy them like I want. All right, moving on. Sorry about that. I didn't mean to ramble on. All right. So in the history taking. So once any life-threatening issues are under control, your next step is in a behavioral emergency is going to be that history taking piece. So we're going to start by investigating the patient's chief complaint, right? So if it's possible, we're going to remove the patient from the stressful situation to help them calm down, okay? We're going to keep your questions focused on the immediate issue to avoid any type of confusion. Establishing rapport is going to be key. That's key in every single call we go on, not just to our patients, but to our partners, not just our partner in the truck, but our partners in service, so on and so forth, is establishing rapport. And a lot of times we fall short of that, as some of us definitely know. So what we're going to do is we're going to establish that rapport. Patients that are in a behavioral crisis, they need to feel that they can trust you, right? So we're going to use therapeutic interviewing techniques, okay, for this. So like speaking calmly and avoiding threatening actions or statements. We're going to limit physical contact, and that's going to help reduce their apprehension, okay? It's also going to be crucial to evaluate the potential for suicide or harm to others while we're doing this. So we're going to pay attention to any recent triggers, such as things like depression, the loss of a loved one, financial setbacks, or drug use. All right. So a patient who has a detailed plan and access to the means of self-harm is going to be at high risk and it requires immediate intervention from that. So we realize this self harm is possibly an issue, okay? Harm to themselves or others. So while gathering information, we're going to involve family members, friends, or even bystanders, even. They can provide some useful insights into the patient's history themselves, even if the bystanders is doing immediate history, right? So while mental health professionals often use reflective listening, which involves repeating back, we call it mirroring. All right. It involves repeating back what a patient says. You may not always have time in EMS to do so. All right. To do exactly that. Still yet, being empathetic, being patient, and also being supportive goes a long way. Okay. If the patient isn't responding to questions, we're going to observe their nonverbal cues like facial expressions, pulse rate, or rapid eye movements if we see that, or slow eye movements, any eye movement. Also, we'll be looking for things like blank stares or rapidly moving eyes that may indicate central nervous system depression or stress. Right? And then finally, from this, we're going to consider the patient's overall state. So their central nervous system function, their environment, any signs of substance abuse, and psychogenic factors like severe depression or trauma. We're going to assess their intellectual function, their mood, their speech patterns, and also their motor activity. We're also going to be sure to document all these findings very thoroughly, right? Because as this information is going to be very important for future care. If it ain't on paper, it's vapor. All right. So during a behavioral emergency, your secondary assessment focuses on identifying any underlying physical causes for the patient's behavior. While much of your evaluation involves interviewing the patient about their psychiatric history, don't overlook any physical clues that might point to an organic issue. All right. So we're going to start off by taking vital signs. So this can give you immediate insight into conditions like fever or increased intracranial pressure, things like that. We're going to examine the patient's skin for temperature, moisture, or even specific tattoos that may suggest some sort of violent tendencies or scars that indicate possible self harm. A lot going on, right? We're going to look at head trauma because head trauma is a common cause of behavioral changes. So we're going to inspect for any evidence of injury. We're going to check for pupil size. We're going to check for the equality and if they're reactive to light for this, right? Getting that pearl. And then what happens is like abnormalities, they can signal toxic ingestion or intracranial pressure changes, right? If your brain swells, then it puts pressure on the ocular nerve, and that's what causes your pupils to blow. All right. So some other things too is we're going to use another sense, smell. So smell is going to be very important. Odors like alcohol, poisons, or ketones on the breath may point to intoxication, poisoning, or diabetic ketoacidosis. Okay. So extremities should be checked for your extremities when you're checking that out, should be looked for needle tracks, tremors, or any type of unilateral weakness. And if they have that, that could signal a substance abuse or a neurological problem for that patient. If there's no significant trauma and depending on transport time, the secondary assessment, it might be brief or it can even be deferred. So, however, we want to always make sure that the effort to obtain vital signs like blood pressure, pulse, respiration rate, and skin condition, we're gonna do that. So these measurements they won't worsen the patient's distress, and they shouldn't, and they may reveal some critical physiological issues with the patient, such as if we're talking about like your diabetic disorders or head injuries, anything like that. And that could be what's triggering the behavioral crisis, right? So we're going to remember that the physical and emotional aspects of the patient they're all interconnected. All right. So also when it's appropriate, we're going to use monitoring devices like pulse oximetry, and we're going to assess first, make sure that we're doing the blood pressure with our actual tools that we have for that manual. We're going to do a manual blood pressure. We're going to evaluate that oxygenation and that circulation without escalating the patient's emotional distress. If it starts to initiate or it starts to bring up that emotional distress, find another way around it. Okay. Always just ensure that you're there to help. That's a big thing. All right. So during transport, reassessment is going to be key. So this is your opportunity to monitor your patient's mental status in more detail. So while some patients may appear calmer, their minds can still be in a state of confusion, which might lead to impulsive actions. All right. So we're going to keep a close eye on sudden changes in behavior, especially as you approach the hospital. If a patient doesn't want help, they may try to harm themselves or even attempt to exit the ambulance, which I've absolutely had and seen. I've been behind an ambulance as somebody jumped out of it. I mean, I've seen it. So when this happens, it could potentially put you at risk as well. We don't want that. So we're always going to be prepared for any unexpected shifts in this patient. We're going to continue monitoring for any medical or traumatic conditions that may worsen, especially those that are identified earlier in your assessment, right? So even minor conditions can deteriorate pretty rapidly when we're talking about in the context of behavioral crisis. Communication is going to be very important. All right. So we're going to make sure to give the receiving hospital an advance notice that you're transporting a patient with a possible psychiatric emergency. So this is going to allow them to prepare the necessary staff and the space for this patient. So if you've had to use any type of restraints, we're going to let them know in advance so they can be ready to safely manage that patient upon your arrival. Okay. All right. Then after that, we have documentation. If you're going to do any of this, you got this documentation that's important. So it's going to be very important for this. So we're going to write clearly and think through your notes to describe the scene accurately. Psychiatric emergencies can be legally complex, and your report may be the only record of what has actually occurred. So if restraints were necessary, be sure to document the type used and the reasons that you had for applying them. Careful documentation for this protects both you and the patient, ensuring all aspects of care are going to be clearly outlined in these cases. All right. So when caring for a patient with a psychiatric problem, we're going to follow the approach that we've discussed throughout this entire thing. We're going to keep the situation calm, safe, and controlled. So your safety and your patient safety are always going to be the top priorities. So one way to maintain control is by placing the patient on a stretcher with the straps secured, right? So this not only provides stability for transport, but it's going to give you more control if the patient becomes violent. So we're going to restrain those violent patients when it's necessary. And when we do so, we're going to follow our protocols, right? But remember, this is a last resort. This is going to be a last resort. We're always remain with the patient unless the situation becomes unsafe. So being present is it reassures the patient and it helps you monitor for any sudden changes that can occur. So we're going to avoid, and we're going to definitely do this, we're going to avoid invading their personal space. So we're going to ask for permission before we touch them. We're also going to explain any procedures beforehand, and this is going to help reduce anxiety. So keeping the patient informed, it builds trust and cooperation with your patients. We're going to try to eliminate or reduce any distressing factors in the environment. We're only going to perform procedures that are absolutely necessary to avoid overwhelming the patient. So this is a time to be sensitive, and it's going to be a time to also be patient with your patient. We're going to avoid any type of judgment about their condition. Remember that the patient did not choose to experience this crisis, and it should be treated like any other illness or injury. So we're going to approach it with empathy and professionalism as always, because we're all that. So lastly, if you suspect the patient has taken any substances, whether it's intentional or accidental, be sure to bring any drugs or substances found on the scene to the medical facility if we can do so safely. So this information, it can be crucial to determining the best course of treatment for your patient. All right, one specific emergency that you may encounter in acute psychosis or that you may encounter is going to be acute psychosis, which is going to occur when a person is in a state of delusion and they're disconnected from reality. So for someone experiencing psychosis, the line between what's real and what's imagined is going to be very blurred. So this can manifest in different ways. So some patients may be angry and belligerent, while others might be silent and withdrawn. Okay. So the causes of a psychotic episode, they vary. And they often stem from a use of mind altering substances. It could be intense stress causes it, or mental health conditions like delusional disorders, or it can be schizophrenia. So these episodes, they can be short lived, maybe lasting only a few hours or days, or they may persist for much longer, even for an entire lifetime. So when assessing a patient in acute psychosis, you'll often see disorganization and disorientation. So these symptoms are common in conditions like schizophrenia or organic brain syndromes. It's going to be important to recognize that the patient's behavior is not going to be intentional and they are experiencing a distorted version of reality. Okay. So during your assessment and your management, we're going to maintain calm, non-threatening approach to this. Okay. So we're going to be patient as always. We're going to explain everything that you're doing, and we're going to avoid any sudden movements that could escalate the situation. So your goal is going to be to help the patient feel safe while ensuring their behavior doesn't endanger themselves or others. So remember that psychosis is a medical emergency that's going to require both empathy and careful management in this. All right, next, let's discuss a little bit about schizophrenia because I've mentioned it a few times. So this is going to be a complex mental disorder that is challenging to both define and to treat. Okay. So schizophrenia, it typically begins in early adulthood with symptoms becoming more noticeable as time progresses. All right. So the disorder is going to be influenced by several factors that include brain damage, genetics, or some sort of psychological or social influences. So patients with schizophrenia, often they're going to experience a wide range of symptoms. So the most prominent are going to be delusions and as well as hallucinations. So they may hear voices or they may see things that aren't there. So and this can make their perception of reality very different from ours. So other common symptoms include a lack of interest and pleasure and erratic speech. So whether communication may seem disorganized or difficult to follow. So when we're managing a patient with schizophrenia, it's going to be important to remain calm and patient. Their delusions and their hallucinations are very real to them. So challenging the beliefs or trying to correct them, we're not going to do that. We're going to avoid that. Instead, what we're going to do is we're going to focus on providing reassurance and keeping the environment as stress-free as possible. We're going to explain your actions clearly, and we're going to ensure that the patient understands what you're doing and why you're doing it. See how we're not playing into anything? What we need to remember is that schizophrenia is a long-term condition, and the patient may develop ways to manage it. Still, during a crisis, that it may require that you support that patient to regain some sort of stability and safety for them. All right. So we're going to approach each interaction with empathy and then understand that this disorder profoundly impacts their ability to function and to interact with the rest of the world. All right. So when we're assessing a patient experiencing psychosis, you'll often notice that their speech is incoherent or rambling. A thorough examination may not be possible due to the patient's disorganized thoughts. So, and also their behaviors. All right. We're going to realize this. So, as an AMT, your primary goal is to transport the patient to the hospital and in an atraumatic and safe manner, right? Atraumatic mean none. I like using those A meaning not or without or not happening or not there. All right. It's going to be important to keep the calm in the whole situation and avoid any type of escalation of the situation. So one helpful tool to remember the signs and symptoms of psychosis are going to be the coast map mnemonic. All right. So coast map mnemonic is going to start off with consciousness. If the patient's consciousness fluctuates, This might suggest an organic brain syndrome. Next is going to be orientation. So, disturbances in orientation, such as confusion about time or place, are going to be more common in organic disorders than in psychotic episodes. Up next, we have activity. So, psychotic patients are often hyperactive and agitated, though they may also show diminished activity. Up next, we got speech. So, the patient's speech might sound pressured, or they may use strange invented words. All right. After that, we have thought. So, thought disorders are common, such as flight of ideas, which means like jumping between topics, loosening of associations, or delusions, particularly of persecution. So, the patient may believe that their thoughts are being broadcast. They also may be inserted or withdrawn by outside forces. Okay. Then up next is memory. So memory may remain intact, though it varies. It may vary. Up next, you got affect and mood, which we talked a little bit about earlier. So psychosis, it often disturbs mood and affect. It may be inappropriate to the situation. All right, then lastly, we have perception. So with perception, auditory hallucinations such as hearing voices are going to be frequently reported as in our psychosis patients. So recognizing those signs helps you to manage the patient more effectively. The goal is going to be compassionate. It's also going to be to transport to a medical facility where further treatment can be provided for that patient, an appropriate medical facility, right? Also, so managing a patient experiencing psychosis, it can be very challenging. As we saw in the last one, there's a lot to think about. So as traditional methods of reasoning, they often don't work. That's why it's so challenging. So it's going to be important to recognize that the patient may be disconnected from reality, making communication very difficult. So you're going to use your feelings of discomfort as a guide to assess the severity of the situation and adjust your approach accordingly. Let your gut do the thinking for you in this. So a disorganized patient, they crave structure. So it's going to be essential that you provide that structure. So what you want to make sure that you do is you speak in plain language. You're going to explain what you are doing and what the patient's role will be in this, in their own care. And then direction should also be simple, consistent, and firm. All right. And this is going to help this is going to help to this is going to help to avoid any type of confusion. So as you interact with the patient, we're going to continually reorient them to time, place, and the people that are around them. And we're going to reassure them with calm reminders and also pointing out familiar landmarks that can help ground them back into reality. Okay. So it's going to be important to use what's called non-pharmacological techniques. All right. So when we're talking about managing the psychosis, that non-pharmacologic techniques is what's going to be important. So using things like verbal de-escalation and maintaining a controlled environment, a calm environment are going to be your first lines of defense for this. However, if the patient becomes non-compliant or they start to pose a danger to themselves or others, we're going to consider calling for that paramedic backup so that they can administer a sedative or an anti-anxiety medication for this patient. So in all cases, we're going to make sure that your goal is to keep the patient safe and calm while we're transporting them to the hospital, right? So what's going to happen is that by providing this structure and reassurance, you can often reduce the intensity of the psychotic episode without escalating the situation at all. All right, so one of the most significant factors contributing to suicide is depression. So anytime you encounter a patient who is emotionally depressed, you must consider the possibility of suicide. So it's going to be a common misconception that people who threaten suicide won't follow through. All right. So in reality, a suicide threat or attempt is often a cry for help. And this is going to indicate that the patient is in a crisis and that they can't manage it alone. So immediate intervention is going to be crucial for these patients. We're going to be alert to warning signs. Does the patient seem tearful? Are they sad or are they hopeless and feeling? Are they avoiding eye contact or are they speaking slowly? Are they projecting a sense of despair? If the patient avoids talking about the future, like vacation plans or goals, this can definitely be a red flag. So we're always gonna ask directly if there is any suggestion of suicide, even if it's in a joking manner. Don't hesitate to bring up the topic if you suspect that it's a possibility. So we're going to watch for specific plans that's related to death, things like preparing a will or giving away important possessions. So this is acutely. This isn't like over time. This is acute. So and the reason why is these actions can signal the patient is preparing for suicide. So some other risk factors include unsafe objects in their vicinity, evidence of self-destructive behavior, or an unsafe environment in itself. So we're going to remember a suicidal patient could also be homicidal. So if you feel threatened, we're going to call law enforcement, right? And we're going to call them immediately. So until help arrives, we're going to try to remain calm and we're going to avoid making the patient suspicious or frightened. So managing those situations are going to require sensitivity, awareness, and immediate action so that we can ensure the safety of your patient and your own safety, most importantly, right? All right, moving on to agitated delirium. So delirium is a state of impaired cognitive function where this may be where a patient may experience disorientation, hallucinations, or even delusions. So, when coupled with agitation, which is characterized by restless and irregular physical activity, the situation can become a lot more volatile. So, while patients in delirium are typically not dangerous, agitated behavior may lead them to strike out irrationally. So, your personal safety must always be a priority when we're talking about this, when we're talking about approaching these patients. All right, so some symptoms of agitated delirium may include hyperactive, irrational behavior, vivid hallucinations, and physical signs like hypertension, tachycardia, sweating, and dilated pupils, right? That fight or flight. Hallucinations, which are hallucinations are going to be these false perceptions of reality. They may cause the patient to see you as a threat, right? So agitation, it often results from a biological need to release nervous tension. And this is going to lead to unpredictable physical actions if left untethered, right? So if you can safely approach the patient, you need to remain calm, supportive, and empathetic. We're going to use what's called active listening. What we're going to do is nodding and limiting interruptions. So shut up and listen. And we're going to show the patients that you are engaged to what they have to say. And then also, when walking up to this patient, we're going to be slow. We're going to respect that patient's personal space and we're going to minimize any physical contact. We're never going to leave that patient after that unattended unless the situation becomes unsafe for ourselves, right? So during your assessment, we're going to ask simple, non threatening questions. So things like, when did you first notice these feelings? So things like that is really going to help. So we're going to evaluate that patient's orientation, their memory, their concentration, and then their judgment. We're going to do that indirectly. So we're also going to take note of their mood, their communication clarity, their appearance, and also their hygiene. So if the patient becomes a threat to themselves or others, we're going to ensure that you have enough well-trained personnel before attempting to restrain them. Okay. Make sure there's enough people. If an overdose is suspected, we're going to transport all medications and substances to the medical facility. So the patient should ideally be taken to a hospital with psychiatric resources, right? And whenever possible, we're going to avoid using any type of lights or sirens to minimize stress for that patient. All right, moving on to mood disorders. So mood disorders are some of the most common mental health conditions. So this equates up to 21% of the US population experiences disorders. And these disorders are going to be things like major depression or manic depressive illness during their lifetime. Okay. So these orders, they They cause significant changes in mood, and they can severely impair a person's ability to function. So there are two main categories. You have the unipolar mood disorders, where patients experience either depression or mania, and bipolar mood disorder. And this is where patients alternate between mania and depression. So, first off, let's start off with mania. One of the most striking psychiatric conditions is going to be mania. So, people in a manic state often exhibit abnormally high levels of happiness, joy, or euphoria combined with hyperactivity and insomnia. So, they're typically awake and alert, but they're easily distracted. So, mania is characterized by rapid shifts in thought. Patients may experiencing flight of ideas or delusions of grandeur, making it very hard for them to focus. So while their memory may be intact, it's going to be influenced by underlying delusions. So they may even experience these psychotic symptoms. And these can be symptoms such as like hallucination. So due to their heightened state, they're prone to risky behavior in this. And often they don't recognize their need for treatment at all. All right, moving on next, we got depression. So, depression, on the other hand, is a leading cause of disability, particularly in people aged 15 to 44. So, it's going to be more common in women. Depression, it manifests as sadness, crying, and apathy. All right, so while some episodes have a sudden onset, chronic depression, or what they call dysthymic disorders or dysthymic disorders, it can persist for years. So something we use is this mnemonic. We call it gas pipes, GASPIPES. And this is going to help identify key symptoms of depression. All right. So the key symptoms of depression using gas pipes is going to be guilt, appetite, any appetite changes, sleep disturbances, poor concentration, interest lost, psychomotor changes, energy depletion, and suicidal thoughts. All right. So understanding those symptoms is going to allow for better recognition and care for your patients with mood disorders. All right. Talking about neurotic disorders. So neurotic disorders are a collection of mental health conditions that don't involve psychotic symptoms such as, or psychotic system, sorry, that don't involve psychotic symptoms, but they still cause significant distress. So while they lack the intense pathology of mood disorders, their neurotic conditions, it can be challenging and it can also be costly. So among the most common neurotic disorders are anxiety disorders. And this is going to be where fear and apprehension dominate the patient's mood. So one type is going to be generalized anxiety disorder or GAD. So this is going to be where patients worry excessively about everything for no particular reason. So GAD is often treated with a combination of medications and counseling, and this helps patients manage their persistent worry. All right, you also have phobias. So phobias are another form of anxiety disorder. So these patients have an unreasonable fear or a dread of specific situations or objects. For someone with a phobia, confronting the feared situation triggers intense anxiety and physical symptoms like sweating and rapid heartbeat, fight or flight, right? So when treating a phobic patient, it's going to be essential to explain every step before proceeding to reduce their anxiety. All right. Up next, we got panic disorders. So, panic disorder is characterized by a sudden, overwhelming fear accompanied by physical symptoms such as chest pain, dizziness, or a difficulty breathing. So, in women, they're more commonly affected than men during this. And many patients can identify they can identify the exact stressful event that triggered their first attack. So panic attacks usually peak in intensity. They peak in their intensity within about 10 minutes and they can last for about an hour. So during these attacks, you have things like during these attacks, agoraphobia, right? So agoraphobia is the fear of public places. You don't want to be there, right? So that's going to be very common in this issue. To manage a patient with panic disorders, we're going to follow some of the steps that I'm about to talk about. So one being, we're going to separate the patient from panic bystanders. We're going to create a calm environment for that patient, and we're going to reassure the patient that they are safe. We're also naming their symptoms and coaching them to slow their breathing. It helps to regain control, helps them to regain control. We're also going to remember panic attacks can mimic physical disorders. So we're always going to have this patient fully evaluated at the hospital. All right. So when dealing with patients in a behavioral crisis or a psychiatric emergency, medical and legal considerations can become more complex. So legal problems are often minimized when a patient consents to care. So this is which is why gaining the patient's confidence is going to be very crucial. So building rapport and explaining your actions can go a long way in reducing resistance and also ensuring the patient cooperates with treatment, right? So one thing to look at is like mental incapacity. Mental incapacity can take many forms. And this can include unresponsiveness due to hypoxia, drug use, or hypoglycemia, as well as severe stress or depression. So once you've determined that a patient has impaired mental capacity, your next step is going to be to decide if they require immediate emergency medical care. So in many cases, patients in a mentally unstable condition, they may resist your attempts to help them. So it's going to be critical that you do not leave the patient alone, as this could expose you to a legal action for abandonment or negligence. In situations where the patient is resisting care or becoming aggressive, we're going to request assistance of law enforcement. Okay. Law enforcement can help manage the situation safely, especially if the patient threatens you. So your partner or bystanders is going to be what you want to protect as well, right? So in these cases, it's going to be important to prioritize safety while ensuring that the patient receives the necessary care. So understanding these medico legal responsibilities is going to ensure that you're providing care safely and ethically while protecting yourself from these legal repercussions. All right. So in our area, we have police officers, probably in your area too. It's nothing new. We have police officers that are CIT officers or critical incident. They're critical incident team monitor or officers. So these people, you can actually call over dispatch, be like, "Hey, can I get a CIT officer here?" All right. So Charlie India Tango. So what I can actually do is I call them up. A CIT officer comes and they are specifically trained in de-escalation. Some of them, especially when we're talking about youth or pediatric patients, some of them even know some of these pediatric patients or like teenagers, things like that. They may know them because they've been called before or they recognize them or they've been to meetings because they have meetings for it for de-escalation. They get partnered with some of these kids. So it's awesome stuff. So CIT officers, they're an amazing resource that we have as EMS professionals to be able to call back on during these psychiatric episodes or anything where you may be having some trouble with somebody on a behavioral level. All right. So in behavioral emergencies, understanding consent is going to be very critical. So especially when dealing with patients who may not be mentally competent to make decisions. So in cases where a patient is unresponsive or clearly not capable of granting consent, implied consent applies. Okay. So this is covered under the emergency doctrine. All right. And this is so emergency doctrine, it assumes consent because immediate care is necessary to preserve life or to prevent further harm. However, in situations that are not immediately life threatening, emergency medical care or transport may be delayed until the proper consent is obtained. So when you're unsure whether to proceed, we're always going to consult our medical control or follow your local protocols. And this is going to help you to ensure that you're acting appropriately. So, consent can be especially tricky in our psychiatric patients. So, in all of our psychiatric emergencies. So, you need to determine whether a life threatening emergency exists. If the situation is unclear or if the patient is resisting care, it's going to be pretty wise to request law enforcement assistance. So their presence not only helps maintain safety, but it can also assist in making sure all medical legal requirements are met. So being aware of these consent considerations is going to ensure that you're providing care both ethically and legally in these challenging situations for this. All right. So as an AEMT, you have a limited legal authority to require or force a patient to undergo emergency medical care when no life-threatening emergency exists at the time. So patients have the right to refuse care, even if it could save their life. However, most states have legal statutes regarding the emergency care of a mentally ill or a drug impaired individual. So these statutes, they often allow law enforcement personnel to place a person in protective custody to ensure that they receive the necessary care. In some cases, medical direction may also order a patient be transported against their will. Okay, in some cases. So when we're talking about those questions earlier, overall is the what we need. We need for sure. So it's going to be essential to be familiar with your local and your state laws for that. And that's going to be regarding any of those type of situations as rules can vary from state to state. So the general legal principle is that a competent adult has the right to refuse treatment. However, in psychiatric emergencies, if you reasonably believe that the patient could harm themselves or others, a court could likely consider your actions to provide life-saving care as appropriate. And that's where that one that I don't really agree with, it may be more of the reading and the verbiage of it that is terrible about it. So, like, you're looking at it from a reasonable adult standpoint, right? And so from looking at that, it doesn't seem like that's absolutely incorrect. However, it would have only taken a few more words, somebody saying something like the neighbor notices, hey, or the neighbor says, this isn't the first time this has happened. And this person we have found to be in various states of their diabetic emergencies that we've been able to clear before. And we keep arriving and they're not compliant with their medications. There's got to be some more history, some more background there. And that's going to be up to your assessment. So wherever that question came from, they gave a terrible assessment. They didn't question it any further, it looks like. I want to make sure we do that, right? All right. So adding on to that, a patient who is impaired, whether by mental illness, medical condition, or intoxication, they may not be legally competent to refuse treatment or transport. So those situations are some of the most legally complex that you'll ever encounter. So we're always going to consider or we're always going to consult your supervisor, law enforcement, or medical control. So when in doubt, we're going to err on the side of treatment and transport. It is far easier to defend against accusations of battery than to justify leaving a patient in need. This chapter is always confusing. It's always confusing. So if you feel confused, I've been doing this. This is 22 years now. I stay confused on some aspects, and that's because it's so complex legally. All right. Restraint of a patient is going to be a serious matter. And generally, it's going to require an order from a physician. It's going to require an order from a court or a law enforcement officer. All right. So if you restrain someone without proper authority in a non-emergency situation, you could face legal action or personal danger at that point. So some things that can happen is like potential charges could be brought against you, like assault, battery, false imprisonment, or even violations of civil rights. So you are allowed to use restraints only in situations where you need to protect yourself, others, or the patient from bodily harm. However, you must use only the minimum reasonable force that is necessary. So since interpretations of reasonable force, they do vary, we're always going to consult med control and involve law enforcement before attempting to restrain a patient. So law enforcement can provide physical backup and they can act as a witness and offer the legal authority if restraint is required then. So if a patient is in law enforcement custody and requires restraint, they remain in law enforcement's care. That makes sense. They are in law enforcement custody. They will remain in law enforcement care. Still, we're always trying to transport patients without restraints when it is possible. Okay. So if the patient is spitting, we can use a surgical mask and we can ensure that you take our standard precautions for this as well. All right. So when restraints are necessary, we're going to ensure at least 4 people are present. All right. So each is going to be responsible for one extremity. So before restraining, we're going to discuss the plan of action and then we're going to stay out of the patient's range of motion. So throughout the entire process, we're going to talk to the patient to keep them calm and then we're going to treat them with dignity and respect always. We're going to try to avoid using excessive force or any action that could harm the patient. We're also going to continuously monitor the patient's airway, their breathing, their circulation, right? Always their ABCs, especially in restrained extremities, and never place the patient face down or anything that could compromise their breathing. Also, along with this, as that we are going to document every single tiny thing, including the reason for restraint, most definitely the techniques that we used, and then witnesses that were present that there on scene. So one thing to remember is that we need to stay vigilant if a combative patient, they suddenly become calm also, because this can be a warning sign of an escalation to come. So a combative patient becomes calm, that dude's getting prepared to attack. So pay attention to what's going on. All right, PTSD is a mental health condition that can develop after exposure to a traumatic event. Whether it happened recently or in the distant past, the trauma could be a single event or a series of events experienced over time. So it's estimated that 7% to 8% of the general population will experience some form of PTSD symptoms at some point in their lives, right? All right, so knowing this, some signs and symptoms of PTSD are going to include things like feelings of helplessness, anxiety, anger, and fear. So people with PTSD, they often avoid anything that reminds them of the trauma. The sympathetic nervous system or the fight or flight mechanism we talk about all the time, what happens is it becomes overactive in individuals with PTSD. And this is going to lead to continuous arousal that is difficult to suppress. So this results in things like increased heart rate, dilated pupils, elevated systolic blood pressure, sharpened senses, and a heightened mental alertness. So PTSD sufferers, they may relive their traumatic experiences through intrusive thoughts, nightmares, or even flashbacks. Sometimes recent events can trigger old memories, and this can cause a reflexive reaction of preparing for danger. So in some cases, people with PTSD, they often associate, or I'm sorry, people with PTSD, they experience this dissociation where they mentally disconnect from the trauma in an attempt to escape any overwhelming distress. So something to think about, like combat veterans in particular, they may struggle with guilt, shame, paranoia, hostility, and depression. Okay, all part of this PTSD. So these feelings, it can make it harder for them to reintegrate into daily life in these instances. So when working with individuals with PTSD, it is going to be essential to remain calm. We're going to remain patient and we're going to remain understanding. And while we're thinking about this, we got to take care of ourselves and everything else because they can be highly reactive to their environment. So we got to maintain that safety aspect. All right, so looking at returning combat veterans. All right, this is definitely something that I like to look into. Most definitely coming from the military and being a military medic, and still doing that. I think about this stuff all the time, or we are confronted with this on a very regular basis in our settings. So, caring for a combat veteran with PTSD, it requires a unique level of understanding. Also, this your compassion and that specialized attention is going to be needed. Veterans are more likely to harm themselves or have a higher risk of early onset conditions such as like heart disease and type 2 diabetes, along along with a loss of brain gray matter. Okay. So many veterans, they also experience high cholesterol and hypertension in this, often undiagnosed or misdiagnosed, all because of things that have happened, right? So, one major concern with combat veterans is the increased likelihood of traumatic brain injury or TBI. So, it's often caused by an exposure to explosive devices, is what's going to be anything that can damage the brain, anything like that, right? So TBI, it can go undiagnosed because its symptoms it overlaps with PTSD, or because veterans may downplay their symptoms. So when treating a combat veteran, it's going to be essential to create a calm environment. Also to eliminate excess noise. That's going to be important. And to be cautious not to touch or to perform any procedures without first providing a clear explanation as to what's going on. Things like small triggers, like diesel fumes, even can bring back traumatic memories. So we're always going to approach with sensitivity. We're going to listen very carefully to their concerns, and we're going to take the time to establish rapport with these patients. So uh, another thing is like how you phrase your questions is also going to be critical, as you don't want to inadvertently cause any type of distress, right? So think about that as well. Caring for those patients, it requires respect and also mindful approach for this. So by taking the time to understand their unique challenges, you'll be better equipped to provide the care that they need. So patient assessment management or these for psychiatric emergency, going to be amazing. And it's psychiatric, so it's not going to be that bad. All right, who wants to do it tonight? I'll take volunteers first.
I don't mind messing up.
All righty. All right. Well, you're definitely not gonna mess this one up. This is good stuff. All right, so here we go. Let's knock it out. So you've been dispatched to a private residence for a 41-year-old male experiencing a psychiatric emergency. The family reports erratic behaviors, shouting, and the patient he's potentially a danger to himself and others. All right. So what can you determine from that information?
Immediately, I can determine that the scene is probably not going to be safe, and I need to wait on law enforcement to clear it before I go on scene. Sounds like the patient's agitated and probably going to be safest to proceed with a calm demeanor and try and calm him down to start with.
Okay. All right. So yeah. So at this point, you should be recognizing that you're possibly dealing with a behavioral emergency, right? This could be caused by factors like mental illness, substance use. It could be a medical condition. So something like hypoxia or hypoglycemia could be causing this. So based on the family's description here, you should be prepared for a potentially volatile situation. So in this, you might need to engage that law enforcement factor like you were talking about. Or if you're able to do so, you have the training to do so, use de-escalation techniques to keep the scene safe. Okay. So all right. Arrival on scene. What do we have to do first?
So first thing is make sure that the scene's safe and your partner's safe.
Okay.
Uh, Determine how many patients there are and what exactly is going on with the patient.
Okay. So Absolutely right. So you're gonna verbalize it. If we're going down our sheet right, we're gonna verbalize that is my scene safe? And so ensuring that scene safety, checking for hazards, and also making that initial determination of law enforcement is needed, assessing that behavior from a distance, looking for any type of signs of agitation, any potential weapons or environmental risk. You may at this point you're starting to form that general impression, right? So of that patient's mental state. So up next, you're looking at things like you're gonna may come up. You may introduce yourself calmly. You may speak in that non-threatening manner. You may want to make sure you keep that safe distance and minimize any physical contact to avoid that patient from just not doing so well. Right.
Right.
All right. So hitting up that scene size up. All right. Keep on. Let's hear it.
So, like I said, determining what exactly is going on with my patient, what my nature of illness is, how many patients, if I need
So you
law
got one
enforcement or
patient.
not, see if I need law enforcement or not. I know
Okay.
it's on the screen right there. Consider she's fine just for
Okay.
verbalizing it, but
Yeah, considering it, but at this point, you really can't make that determination, right?
right.
Because you don't want to put your hands all over them if you don't
So,
need to.
is that my
Uh,
patient sitting there on the porch?
no, that's just a picture. I always keep that one up there. He doesn't look like he's agitated at all.
No, he looks pretty calm.
All right, so the patient is pacing back and forth. He's muttering under his breath, occasionally shouting incoherently, right? So there's
Right.
no visible weapon, but the patient is moving erratically and they look agitated. All right. So uh, like you said, you want to consider that law enforcement either stand by or nearby or be there.
Uh,
So you want to go ahead and call them up, tell them to come on in.
right. Oh,
See, go ahead.
there, and also continuing on with the primary impression of the patient. If they're up and moving around, obviously. My ABCs are covered. They're talking, moving around, screaming, hollering. They're moving air. They're moving blood. So I know that on my primary assessment, my ABCs are good.
Okay. All right. So your one patient, that 41-year-old male, he's having his psychiatric emergency. Just to get things that way in case you're taking notes. Additional resources, you called up, the patient's continuing to pace as you called him up, becoming more agitated because now you're just sitting there staring at him, right? Trying to and
Right.
talking on your radio. So he's automatically thinking, well, he's talking about me, and he's getting mad. So he's yelling at unseen figures. He's refusing to acknowledge your presence, but he knows you're there. You'd call for that law enforcement, possibly a paramedic backup, because this could possibly be something that they may have to Haldol, some sort of Ativan, like that to possibly assist with knocking this patient down, right? That C-spine, not really much we can do right now, so we're not considering it at this point.
No.
Good job. All right, moving on. You talked about the general impression. I give that sick or not sick, right?
Right.
So the patient, they appear agitated, they pace back and forth, rapid, disorganized speech. He occasionally shouts and screams, confused or disoriented, acting like his movements are erratic, but there are no visible signs of trauma or self harm. So, that general impression is going to indicate that the patient is an acute psychiatric emergency with agitation and potential risk to himself or others. And then, scene safety at this point is still going to remain your top priority for this.
All right.
So, level of consciousness, the patient is alert, but he's not oriented to time, place, or situation. So his speech is scattered and he does not seem to be fully aware of his surroundings. So we may announce that as patient is alert but disoriented, all right, which
Copy.
is very common in psychiatric crisis, right? All right. So continue your assessment while maintaining a non threatening posture. That's what's going to be important.
Copy.
All right. So what is the patient's chief complaint at this point?
Some type of behavioral emergency, agitation, upset.
All right. What's next?
Like I said, obviously can assess from afar. He's maintaining a patent airway. If he's up and moving around, he's got good circulation. He's breathing. Um, Patient kind of determine my transport priority himself. It's going to be treatment right now because can't can't get him into the ambulance. We
Mhm.
gotta work on that.
Okay. So one thing, like it says here, O2. Would you
Mhm.
feel comfortable on putting an O2 mask on this person at this point?
No, no, not really.
Yeah. So, despite there being some sort of they're adequately ventilating, despite that he may be agitating or anything else, maybe some mild hyperventilation, I would say that there's no immediate supplemental oxygen needed just because he's not showing me, I'm not seeing the hypoxia just yet, and safety. Safety. All right. So, looking at circulation, there's no major bleeding, of course. His pulse is rapid but regular due to the agitation. Skin is pale and slightly diaphoretic, indicating some sort of heightened sympathetic nervous system activity.
Correct.
All right. Now,
So,
moving. Go ahead.
oh, I think I was fixing to jump ahead anyways. I was gonna say next on going down. If he's not talking to me or answering me, if there's any family that I can get uh history from, things like that.
Okay. So at this point, what type of priority or treatment do you think you could do with this patient, or would you want to do?
Well, I mean, I'd love to get a baseline vital signs on him.
Okay. So what do you think we need to do? Because right now, so treatment doesn't always have to be a drug or a monitor or anything else. We talked about treatment for these patients may actually include what?
Talking to him, trying to calm him down.
Awesome. Awesome. Exactly right. So your focus at this point will be on calming the patient and ensuring safe transport to a facility that's equipped to handle that care, right? That psychiatric emergency. If
Yeah,
you can get him to do that. If he becomes a threat, if the patient becomes a threat, what can we consider?
depending on what resources I have on me, uh, be physical restraints if it come to that point.
Hmm.
We
And
also
if we,
get backing out of the scene until we get further resources.
yep, and yep, you sure can, or keep him calm until those resources arrive or what have you. But as soon as they arrive, there's a possibility he can become more agitated. Another thing is too that paramedic backup, that paramedic may be able to provide chemical restraint to help you out as well.
Sure.
All right. All right. History taking. So go ahead and ask the questions. I will answer them to the best of my psychiatric distress knowledge.
Well, asking my patient or a bystander.
So just talk to the patient first because sometimes that's worth it. You're not talking around them. You talking around me type thing, and then they get agitated. Try
Yeah.
them out first.
Yes. So when exactly, or when when did you start getting agitated? When did all this start coming on?
So they're coming for me. Can't stop thinking about it. I don't feel safe anywhere. I just can't stay still anymore. This patient is very visibly agitated, pacing, and struggling to focus on the question that you're asking.
Gotcha. So who's coming for you? Who are you worried about?
Well, you asked me when it started. It started a few days ago, but it got worse last night, and I couldn't sleep. Kept hearing noises. I thought someone was in my house.
Yeah, that's not good. Oh, I was at this point still trying to reassure the patient that it's just us there, and we're tracking with that and trying to keep the patient calm while I'm asking what again
And I
what he's
still
worried about or what he's worried about.
And me, I still go through OPQRST. I still go through, but it sounds more calming and effective. So you may say, has this feeling been getting worse or has it been staying the same since it started? That provocation piece.
Gotcha.
So the patient would tell you, it's getting worse. I can't calm down. Nothing helps. Nothing. All right. And so the patient starts rubbing their head, looking around as if they're hearing something. All right. So you
Right.
see that a lot.
So tracking here for a second, how would you question the the quality of it? How do you ask that question?
So the
Hey,
way I would ask that for this type of thing, and I know OPQRST is usually used for pain, but it has so much more ability that we're not even touching into. So for quality, I would ask, can you describe exactly how you're feeling right now?
Tracking.
Yep. And so the patient would say, I feel scared, like something terrible is going to happen. Keep thinking I'm in danger. Can't stop these thoughts. All right. So the patient, and as he's saying this, his speech is getting faster. He's jumping between thoughts when he's talking to you.
So for the radiation of that, I would ask something along the lines of, does anything make it worse? Any sounds, any sights? Does anything make it worse on you?
So really, that's going to be more of a provocation
Okay.
for radiation. You may turn it into, do these feelings happen all the time or do they come and go?
Tracking.
So the patient then may say, if you ask that, the patient may be like, it, it's worse in waves. And sometimes I can distract myself, but then it all comes back and it's like I can't think about anything else. So now at this point, when you hear that, you recognize like, hey, this is something that's ongoing, so much so that the patient has figured out some sort of coping ability with this psychiatric distress. So this may not be acute.
Gotcha. So on severity, would that be a more of a, does anything make it worse or better question? Or
No, so you just like you would pain on a scale of 0 to 10, how bad is this feeling right now? And the patient say, it's a 9. It's a 9. It feels like I'm going to lose control. But he's talking to you. If somebody's talking to you, that means a lot.
right, right. And so how long has um, this instance been going on? How long has this initial problem been happening?
So for time, what I generally ask, that's a good question. So for time, I generally ask something maybe for psychiatric. Can you remember what you were doing when this feeling started? Was it something specific that triggered it? So now we're trying to find that triggering event, right? So for time. So the patient say, I was just sitting at home trying to watch TV and suddenly I felt this panic rise up. Since then, it's just been non-stop. Okay.
I'm glad I volunteered for this one because I struggle with the behavioral side of things.
Yeah. No, it's great. And this is what we should do. We should be challenging ourselves and stepping outside our comfort zone. Always. That's how we learn. All right. So clarifying questions. If we wanted to clarify some questions, what may we ask? And just to give you a hint, this is something that we should ask every psychiatric patient.
Just more bluntly, do you have any thoughts of hurting yourself or other?
Man, that was absolutely the exact question I was looking for. So, have you had any thoughts about hurting yourself or anyone else? Awesome. So the page says, I don't want to hurt anyone, but sometimes I think I'd be better off if I wasn't around. All right.
Sure.
So then the patient, at this point, the patient's voice becomes more subdued. So, which means that they're the suicidal factor, they're downing on themselves. Two, they're opening up. That rapport is building.
Sure.
Okay. Some other things that you may ask for clarifying questions, maybe have you noticed any changes in your eating, your sleeping, or other routines? And the patient may say, I haven't eaten much for days and I can't sleep more than an hour or two before waking up in a panic. All right. You may ask, have you experienced anything like this before? Trying to get the historical factor, right? You
Have
say,
you
yeah,
swapped medications or
yeah,
started taking anything new or run out of anything?
absolutely. Absolutely. That'd be great. For experiencing anything like this before? Yeah, once years ago. I didn't get help then though. So then we move into our tried and true sample. So starting off with signs and symptoms. So like saying something like, do you have any medical conditions I should know about?
Uh-huh.
And patients say, nope, really, just this panic and fear. It's all in my head.
Checking. Are you allergic to any medications or any natural allergies?
I was, well, oh, sorry. I skipped ahead on myself. No, no allergies that I know of.
Gotcha. And so we've already covered the medical history there.
All right.
Um,
So I was taking something for
allergy.
my I was taking something for my anxiety a while back, but I stopped because it made me feel like a zombie.
And what was that?
I don't remember what it was called. I don't remember what I was called or what it was called.
The P would be past medical history, and we covered that, right?
Yes. Yeah.
Uh,
So things like, it happened a long time ago. So you something like, can you tell me anything like, has this happened before or been hospitalized for this kind of condition? So patient tells you past medical history. It happened a long time ago after a bad breakup, but I never went to the hospital. I just ignored it.
sure. And then, when's the last time you ate or drank anything or took any medications?
Mm, mm, it's been at least a whole day since I've eaten anything that I can think of. I haven't been eating very much.
Sure. And what about drinking? Have you been drinking plenty of fluids?
The same as eating. No alcohol or anything like that though.
Gotcha. I'm tracking Chase. I'm trying.
No, you're doing great. There ain't nothing wrong with what you're doing.
No, what were you doing when this incident started?
Just
Right.
watching TV. I was watching TV and it just started creeping up on me again. Nothing in particular. Just that.
I can't think of any other questions I want to ask for that.
That's quite all right. That's quite all right. You can keep on moving then.
Correctly. So I would want to do a. I'd want to do a more detailed assessment on my patient, even though I know it's a medical or I'm recognizing it's a medical patient. Um,
So
that
you're
as I'm looking at them, I also want to look at them head to toe and make sure there's no evidence of self harm or
right.
anything sticking out that I might need to see.
Right. And before we do that, we want to make sure that we obtain absolute what from this patient?
Permission to treat or examine.
Yep. So we do that. Hey man, I just want to be able to check you out. And if you're not sure where this is coming from or anything else, if you don't mind, let me do a physical assessment so I can take a look. So that means I'm gonna have to touch because this could be an illness thing. It could absolutely be a mental thing, but I want to make sure that there's not something physical happening to you that could be causing this. Is that okay? And then he says, "Yep," or he says, "No, don't touch me." And at that point, okay. And then you're like, "Well, okay. So, do you mind if I look at maybe the whole body, head to toe? Maybe if I just Maybe if I just go to some affected areas, would that be okay?" You're always trying to get to the point of medical care, right? So so now you say something like now that I have a better understanding of what you're going through, I'm going to check a few things to make sure that your body is doing okay. I'm not going to touch you unless I explain what I'm going to do to you first. Is that all right? And so the patient would say, "Yep, that's fine."
Tracking. So I do want to think here. Like I said, behavioral things are more difficult for me on,
Nope, that's all right.
especially on role playing it out there.
Yeah.
To start with, not touching the patient, I'm assessing. I'm closer to them. They're calmer. I'm assessing the breathing. I'm listening, not necessarily with a stethoscope, but I'm listening. What kind of sounds the breathing's coming up. I'm hearing any audible wheezing, anything like that. I'm looking at the skin. I'm looking for JVD around the neck, facial drooping, checking all that. Looking at their eyes, asking them if it's okay to use a pen light and check their eyes. Trying to creep more towards asking if it's okay to check their pulse so I can feel their skin, see
Okay.
what it feels like.
All right. So pulse is rapid, just rapid. Auscultations, you don't hear anything abnormal. Nothing you or feel or anything like that. You feel that anything abnormal. His pupils are equal and reactive, normal size. So that's going to rule out intoxication or visible head trauma, right? So
Correct.
some things that I do for this, like for these patients, when they give me the go ahead, then I start off and this is the trust thing. So I'm gonna say, just like I'm talking to myself, I'm reassuring myself too. Hey, I'm going to check your head and your eyes now. Is that okay? And I ask permission over everything.
Right.
So, or as I'm moving down, I may say, all right, now I'm going to check. I'm going to ask you a few questions to check your memory and focus. Do you remember what day it is today? All right. And so patient struggles to recall the day, but is alert and able to communicate, though they're agitated. I mean, all right, I'm going to listen to your breathing now. Is that okay? And then you use the stethoscope. They say that's okay. Use the stethoscope. His breathing is rapid, but it's clear, consistent with anxiety. So we're not worried about that. No wheezing, no crackles or respiratory distress. That's that pertinent negatives that we talk about. All
Right.
right. Now I'm going to listen and check your pulse and feel your skin. All right. So we always ask before we do anything, we ask, and it's letting them know as well. All right.
Right.
So patient's pulse is rapid and strong, likely due to anxiety or panic, probably. The skin is pale and diaphoretic, further indicating agitation. All right. I'm going to feel your abdomen to make sure that everything is okay there. Let me know if you feel any pain. All right. So at that point, you'll lightly palpate the abdomen and feel for any tenderness, any distension, any signs of internal distress, right?
Right.
So abdomen is soft and non-tender, no signs of distress. So next you would say, I'm going to check your arms and legs now. Is that okay? And you'd move down and you'd check the patient's extremities. There's no tremors, normal movement, no visible signs of substance abuse, anything like that. All right. Then you may ask about in your psychiatric assessment. And that's what I said. These are tough because we don't practice these all the time. So you may say, you may ask, you mentioned that you feel overwhelmed. Can you describe what you're feeling right now? And do you feel like these thoughts are racing or are they slowing down? What's going on? And so at this point, the patient would tell you that there's some sort of racing idea that may be consistent with an acute anxiety or a panic attack. And in doing so, when you're doing this, you're trying to rule out, is there an evidence of any disorganized thought or is there evidence of any hallucinations? But the patient just feels overwhelmed and out of control, if that's what we're looking for. All right. So also you could say, like, based on what I'm seeing, it looks like your body's reacting to stress that you're feeling right now. I'm not seeing any signs of serious medical issues like an injury or an infection, but I want to make sure that you get further evaluation at the hospital. How are you feeling about that? Okay. And then the patient may, if you got that rapport built and you've been letting them know everything, say, I don't know. I just want this to stop. I don't want to go, but I know that something's not right. So from then on, you may say, hey, we're going to help you through this. We're going to help you through this. So let's get you to a safe place where they can take a closer look and letting them know, let's get you to a safe place so we can take a closer look. All right. We may need to keep you calm on the way to the hospital, but you are definitely in good hands. So you let them know, have some confidence in yourself and all that. All right. Awesome. All right. So now the hands-on portion of what we were talking about, everybody that is comfortable with. All right. So go ahead.
So asking permission to put the blood pressure cuff on and
Yep.
the pulse oximetry,
Yep. That's fine. All right. What vitals would you like to get?
a complete set of baseline blood pressure, heart
Okay.
rate, O2 sat, count for respirations, listen to them. Well, we've already listened to them. But our sugar
Might just be diabetic and going nuts. I watched Jeopardy in action. And
and keeping on that list.
oh my God, I might go on.
Yep, it is. You're just helping out.
Yep. Did you hear everything?
Yeah. Oh, yeah, I did. So, all right. So, blood pressure is 148 over 92. Patients, it's elevated because stress and anxiety, fight or flight response, stuff like that. But there's no physical threat. You didn't see that. Pulse rate is 118 and regular. So, tachycardic, right? That's because the sympathetic nervous system, the body is an amazing thing that what it can do to itself. All right. Your respiratory rate and quality is going to be 24 breaths per minute tachypnic, right? And slightly shallow. So that's probably going to be due to that rapid breathing, slightly shallow due to that hyperventilation. from having anxiety or a panic attack.
Copy.
All right. So the patient may also they feel like they can't catch their breath, even though their oxygen levels remain adequate. All right. So something to think about there. Their blood glucose, because we always want to check that too, is 105. All right. So patient's blood glucose, that's normal.
Yep.
That's within normal limits or adequate, right? And that rules out hypoglycemia as any type of contributing factor for this. All right. SpO2 you asked for is 98% on room air. So O2 sat within normal limits, right? So
Right.
adequately oxygenated. Some other findings that you may look into, their skin, we already talked about, was pale, cool, slightly diaphoretic, pupils equal and reactive to light. What is your field impression for this?
Uh,
What when we're talking about disorders that we talked about throughout the chapter, what type of disorder do you think this may be pointing to?
I feel like the patient suffer from more of a acute anxiety.
Okay. So yeah, so like an acute psychiatric emergency, anxiety, panic disorder, or even that agitated delirium, right? So elevated vitals, their BP, heart rate, R&R, they align with that sympathetic nervous system distress. And that there's no immediate medical concerns for you. So that's good to go. All
The
right.
only intervention that I'd want to do as far as trying to still keep the patient calm is try and coach them on their breathing, try and
Okay.
breathe down and see what that would do for resting vitals.
Awesome. Okay. Good. All right. So some things that I learned in reading things like that is going to be like you reassure that patient, "Hey, we're going to help you through this. You're safe and we're going to make sure that you get the right care that you need." So one thing that I've learned, it talks about speaking in a calm, low tone to reduce that anxiety. I call it the midnight DJ tone. So when you talk to somebody, you get a low voice and you talk to them in a normal manner and you slow it down so that they can understand what you're talking about, which is absolutely against what I'm usually doing because I usually talk really fast. So you get that low DJ voice, that low midnight DJ voice kind of thing. And you're talking that way, they feel like you're talking to them. Another thing is too, is that as they're talking, you're nodding your head, right? You're looking at them, you're nodding their head. Yes. And then you may every now and then do what's called mirroring. So they say something and you say, okay, he said earlier, oh, so it feels like someone's coming to my house. So it feels like somebody's coming to your house. Okay. And you just keep going because that way they know you're listening because you can repeat what they say or a piece of, and it's only got to be 3 or 4 words. So it also works really good with the negotiation too. So you think about it. So using that's going to help. And absolutely, you're doing everything right so far. All right. So interventions, you said that. No need for restraints at this point. He hasn't given you a reason. Okay. All right. So reassessment. How and when would you do this?
I usually about halfway to the hospital or my first set of assessment, everything was spent on transport time. Again, would ask the patient how he's feeling or if anything has worsened or gotten better, questions
Mhm.
like that.
Okay. So perfect. So every 5 minutes or so as you're going through, just depending upon how you feel about what's going on, getting that trending and everything, constantly asking. It's keeping that rapport. You don't Me personally, I don't like to leave that silence there and because silence sometimes it creates anxiety unless they're like, just shut up. But I try to do that too. So you reassess the vitals. And as you reassess the vitals, you get 138 over 86. You get a pulse rate of 102. You get a respiratory rate of 20. You get an SpO2 of 98. You get skin is pale, dry. And so good there. And then you get equal reactive for pupils. So good there. All right. Sorry, I'm going through because I have a list of vitals just in case something didn't go correctly. Everything
Uh,
went. All right, so now you've arrived at the hospital and you've got Nurse Karen. Nurse Karen comes up and says, "Yep, what you got today? Let's hear it." Did I lose him? No, I lost Ben Lenz. All right. He was like, "Well, good enough. I'm out." All right. So I'll continue through. I'll continue through. He did a great
my
job. Okay,
my
you
Wi-Fi was out all of a
all right.
sudden.
Well,
And
you did
so
a great job. All right, so you want to give me that handoff report? Oh, I'm gonna go ahead and do it. All right, so I would come up to the nurse and I would say, "Hey, Nurse Karen, we have a 41-year-old male experiencing a psychiatric emergency. We're dispatched to the resident for family member concerns about any type of erratic behavior and potential danger to himself." He's mentioned that. Think he said something to the effect of, "That's all right." Something to the effect of he just feels like they'd be better off without him. So something like that. I don't really know if we want to call that SI, maybe. So suicidal ideation. All right. So the patient's nature of illness appears to be some sort of acute anxiety or panic disorder. No signs of physical trauma on the patient. He reported rapid racing thoughts, extreme agitation, and difficulty calming down, but there are no physical injuries. The patient presented with elevated vitals. Of course, he had a BP of 148, heart rate of 118, R&R of 24 a minute. He reported this intense feeling of panic, fear with a long or a strong fight or flight response. After we did some verbal de escalation and calming techniques, his vitals started to improve a little bit. However, if he had had any type of worsening agitation, we could have called law enforcement. This was not necessary. The patient showed some, at first, was showing agitation, tachycardia, hyperventilation, and pale diaphoretic skin. He said he reported feeling out of control. He denied suicidal thoughts. At the time, he's just said things would be better if he wasn't around. So that's what we're trying to get at there. So good to go for that. So the patient was, what we did as far as treatment is we did verbal de-escalation. It was attempted, made sure that we stuck with that. And then no need. We didn't have anything needed for anything else. SpO2 was at 98, so no oxygen or anything like that. Airway was continuously monitored throughout. So the patient is currently they're okay. Vitals are good to go, and we give them the last set of vitals that we had. We won't belabor it. All right. Fantastic. All right. So now I'm gonna swap over. That was a great job, by the way, Ben Lenz. So you did.
I'm sorry.
No, that's quite all right. You did a fantastic job throughout the whole thing. You went right down. The whole point of this is to do the systematic, go down that checklist. You did just that. So that's good stuff. And that's what passes that NREMT test, is that systematic process. Today, during our PHTLS class that we were teaching, it even talks about, it's an advanced level course, and it's talking about systematic process. And so, I mean, we know that it works. So most definitely great job. Great job. All right. So now let's go on to the Mentimeter and let's see what we can get done with that. The fun stuff. And I'll go ahead and I'll put I got the link in the chat just in case anybody need to get back on it. I'll give a few seconds before we wrap it up. All right. So, under what condition can you legally transport a patient having a behavioral emergency despite their refusal? Which one is that going to be? Okay. Anybody? Yep. Okay. Anybody else? Okay. All right. All right. So when the patient is presenting a threat to himself or others, when you can legally transport a patient having a behavioral emergency despite their refusal. So when a patient is having this issue, so like we talked about earlier, most states are going to have statutes that allow EMS to transport a patient against their will if they're a threat to themselves or others, right? So this is going to ensure their safety and that of others. If we were looking at acting strange or bizarre, that's not enough to justify forced transport unless the behavior involves a direct threat. If we're looking at the physician, the online physician, there's many states that a physician cannot legally order forced transport unless the patient possesses a risk to themselves or order others. And then for the last one, which is going to be when a patient is confused and disoriented to person, place, or time. So confusion or disorientation alone doesn't really justify involuntary transport unless the patient is in danger, again, in danger to a danger to themselves or others. All right. So we go for the one we know is right. All right. There's no deciding factor on or anything else. I know this one's right. Right. So threat to himself or others. Simple, easy. Awesome. Awesome. All right. So what is the best treatment plan for a hypoglycemic geriatric patient now alert and oriented, but outwardly depressed and refusing transport? So we talked about this one. Not a fan of it. I don't like the one they call the correct answer. Not a fan of it, but this is what it is. Now, when we went through the lesson, it did lean towards the fact that if you want to consider a bout of depression being, and then also coupled with that neglect for their self care with hypoglycemia, and if it keeps happening and keeps happening, yes, at that point, I could probably see how that's a threat to themselves, right? That's a threat to themselves. They're going to wind up hurting themselves through this or dying here alone because they're just giving up. They've given up. They don't want to help regulate their diabetes, so they're just letting it fly. All right. So maybe in that aspect, you could see that. So the explanation for this here is the correct answer being the try to convince the patient to go. If they don't, then hand it in there. So the patient's depression and history of neglecting. So if they have a history of neglecting their health, it may indicate a suicidal tendency or further health risks, right? So attempting to transport even against her will may be the best plan for this. The best plan. All right. So so leaving the patient with a family or friend and assuring that they'll ensure proper care doesn't address the immediate risk of depression and potential self-harm. Even and then also you're looking at even if the medical control approval, leaving the patient at home in her depressed state could lead to further deterioration, right? And then also documenting the neighbor's comments and following up later doesn't really mitigate the current risk to the patient's health. Okay. All right. All right. So which statement best describes the condition of being developmentally disabled? Remember, we talked about the one that we're for sure, the one that we're for sure on. Okay. We got one. We got three. Three for yellow. Good. I like it. Four for yellow. Awesome. All right. So, correct answer being yellow. So, developmental disabilities refer to the cognitive impairments that typically result from Dane Bramage. My mouth is terrible today. From brain damage or a neurological condition that affects their learning or development. So, that's going to be the correct answer, right? So, if you're looking at a behavior that is a side effect of poor upbringing. So this sorry, I was looking at something else. So this describes like a neurosis or a behavioral issues due to the environmental factors, not developmental disabilities. Makes sense? The one that says a patient who loses contact with reality. So this is going to describe psychosis. So this is where there's a loss of contact with reality, which is not the same as developmental disability. And then lastly, you got the last one. It says the appears to the person appears to be cognitively impaired, usually as a result of brain damage. So this is going to describe the emotional or the mental impairment, not necessarily the developmental disabilities of this. So that's where that's going to go. Oh, I had it wrong the whole time. Why did I screw that up? What did I mess up on that one? Oh, I had these two backwards. Oh my goodness. Hey, this is one of those times that I will absolutely call myself wrong. I was absolutely wrong on this. Yep, developmentally. So I was absolutely wrong on this, and that's my fault. So just that's an emotional. Talking about this one is an emotional impairment. So I was wrong on this, and I had them backwards because I was looking at it as the overall, but developmentally impaired due to a brain damage. Okay, that makes it makes some sense. It makes some sense. So I'm wrong on that one. I apologize for being wrong. But you guys did fantastic. Despite my best efforts, you will still pass. All right. I'll have to correct that one. So, what is the best definition of a behavioral emergency? Let's hopefully I can get this one right. Right. This is a good one. This is a good one here. All right. So, with this one, and this is why these are tough questions. So, when a patient's behavior becomes so unusual that it alarms the patient or others. All right. Again, this is another one I don't necessarily agree with for this, but this is what they're calling it correctly. This is the explanation for it. And I love doing these because, like I say, these tests are just as hard for us as they are for you guys. That's why we pick these. All right. So fantastic. And I like how everybody a lot of people stuck to their guns with this, right? I like it. And that's where it's all stick to your guns with something and go. So what we're looking at here is a behavior. So what this is on the correct one, you have a behavioral emergency that occurs when a patient's behavior is so abnormal that it causes alarm to themselves or others, potentially leading to a dangerous situation. All right. So at this point, now it's a behavioral emergency. So looking at A, so deviating or blue, deviating from societal norms doesn't always constitute an emergency unless it causes alarm or harm. Okay. Pretty good with that one. And then B, which nobody picked. So while it could be a behavioral emergency, it doesn't encompass all the situations. Like we talk about the all encompassing, where behavior is alarming, but not necessarily life threatening. Okay. And then D being incorrect. And this is why. So having disorders like anxiety or depression, it doesn't automatically lead to a behavioral emergency unless they manifest in an alarming or harmful behavior. So somebody has to be alarmed by it in order for it to be considered a behavioral emergency. Does that make sense? And that's why these are hard questions. That's why I bring these up. These are very tough questions. All right, so that's it. So moving on from that, let that was fantastic, by the way. Everybody did a great job, except for me. I'm supposed to be teaching this class and I got one wrong. which I guess that just proves that I'm not infallible. All right, let me move this. Sorry, I got to rearrange my entire desktop whenever. I know. All right, so moving on. All right, so as always, I always mention this because I really like to the attendance forms. So make sure we get the attendance form completed that's on your student dashboard or in your student dashboard off the website. Again, as always, your feedback is awesomely important to us and it helps us as instructors get better. All right. So if we don't make the 5 stars or what have you, then let us know why we didn't. Also, give us suggestions. Put on there like, hey, it would be better if, and give that to us as well. It doesn't always have to be, yeah, it was good. I don't want good. I want amazing. That's what I want. So let me know. Quick reminders for this. Attendance, don't forget it. Upcoming reminders for quizzes. So all quizzes as are due by Saturday at 11:59 p.m. But we're going to do them before that, right? They're just due by then. We're going to knock these things out because these are going to be easy tests. So what they're going to cover is going to be, you're going to do chapter 23, toxicology, and you're going to do chapter 24, psychiatric emergencies. All right. So also, by the way, Monday, chapter 25 is going to be gynecologic emergencies. So that's going to be the topic of our lecture on Monday. So make sure you study up, make sure that you're ready on Monday for me to ask questions as well as for you to answer and ask questions also. Okay. So if you have any questions about tonight's lecture or anything else, feel free to stick around after I get off or after I stop recording, and I'll be happy to answer them. If not, if you're all set and ready to go, ready to bounce out of here, feel free to go ahead and bounce out. And if you do, I hope you have a fantastic rest of your night. And thank you for being here with me. All right. Y'all have a good one.